Okay, so we'll talk about bronchiectasis with cystic fibrosis as well in this presentation. So we're combining two conditions, and you'll sort of see as we go through bronchiectasis how much it's related to, or how common it is with cystic fibrosis. So I'm sort of putting them together. Understand cystic fibrosis is usually has bronchiectasis, but bronchiectasis can happen separate of cystic fibrosis. So if that didn't make any sense to you, it's okay. We'll clarify as we go along. But I'm putting them together because there is a lot of crossover with cystic fibrosis and bronchiectasis. But understand bronchiectasis can happen on its own. All right, so bronchiectasis, when we're looking at it, it's characterized, so this is sort of the definition here when we're looking at it. It's characterized by chronic dilation and distortion of bronchi, usually the result of excessive inflammation and destruction of bronchial wall cartilage, blood vessels, tissue, and smooth muscle. Yes, that's a lot of things to get destroyed. We have a lot of inflammation that destroys the cartilage, which is the structure of the airway, blood vessels, which could explain some hemoptysis that you might see with these patients, elastic tissue, which means that there can be the formation of fibrosis in later stages of this, as well as destroying smooth muscle, right? And as well as bronchospasm can easily happen with it as well. So there's a lot of destruction that goes along with this. So as you look through bronchiectasis, it is not something that to be taken lightly. It is a very severe pulmonary condition. It could be one or both lungs involved. Good news there. It's commonly limited to a lobe or a segment and frequently found in the lower lobes, right? Lower lobes. Sort of like panlobular emphysema, more common in the lower lobes. So when we're looking at this, we're going to have those issues. The smaller bronchi have less supporting cartilage and are more affected. So we're looking at sort of that transitional airway or tracheobronchial tree type airways, the end of the tracheobronchial tree to the airways. And we'll see these on CT scans and x-rays that I have as well, so that I'll highlight that more for you. All right, so here is what's going on. You'll see this picture in your book. Of course, there's a lot of mucosal edema that can, or mucosal stuff that can happen with this. Also, there are three primary forms, which is this middle picture and this bottom picture labeled E, is just trying to show atelectasis. So this is a disorder where you can have both hyperinflation and atelectasis happening simultaneously. So that's one of the big issues that you see. So here are the three things, and we'll talk about that more. Here are the three main types. You have this type over here on your far left that looks very irregular. It looks very varicose-like. It looks like an irregular distortion of the airway walls. And so this is called the varicose, right? Like varicose veins, varicose form of bronchiectasis. You also have the cylindrical form of bronchiectasis where they look like long cylinders, long tubes. And then you have your last one over here, which is called saccular, or another synonym would be cystic or saccular form. So there are three types, and we'll get into all three types. And which one do you think would be more common with cystic fibrosis? Hence, it's in the word, right? It would be cystic, right, or saccular form of bronchiectasis. So let's get into this. All right, common lung alterations associated with bronchiectasis, bronchial wall destruction. So their airway clearance is going to be impaired. Their mucociliary escalator is being destroyed, and their cilia are impaired, so they're more prone to difficulty with getting secretions out of their lungs. So please, airway clearance therapy in these patients. Airway clearance therapy. Yes, airway clearance therapy in these patients. These people will accumulate a lot of copious amounts, a lot of secretions. And sometimes they'll even be hemoptysis or blood with them. The other thing too is they might be foul smelling because they might be colonizing an anaerobic organism. Yes, so their sputum would be foul smelling. Have we talked about that yet with chronic bronchitis, asthma, emphysema? No, we have not, right? So this is one of those things that should stick out to you as something we haven't covered yet, is that foul smelling sputum. Yes. Foul smelling sputum, usually anaerobic organisms if you culture it. Infection and irritation usually lead to bronchial smooth muscle constricting. So this means bronchospasm. So not only are you doing airway clearance therapy, but you're also looking at bronchodilators. Now you actually might be doing inhaled anti-infective agents for the anaerobic organisms, depending on what it is, but that's a whole separate thing. But here you're going to see smooth muscle constriction, so bronchospasm is part of this, so say yes to bronchodilators. And then fibrosis. When we get into the later stages especially, there's a restrictive and an obstructive form of this, and so with the restrictive form of this, it's usually because the scar tissue has formed because of the deterioration of tissue over time, right? It's that injury that keeps scarring and scarring and scarring and causing it to get tougher and tougher. It makes it harder for them to get a good deep breath. So this condition, bronchiectasis, can be both restrictive and obstructive. Oh, heavens, right? We tend to think of it as obstructive first, and then as it advances, it tends to become more obstructive and restrictive as a combined condition. The bronchioles usually become partially or totally obstructed with secretions. So that's where you're looking with the secretions sort of blocking those airways. And so what happens here is as you inhale, gas can go in, and then eventually it can get reabsorbed into the bloodstream. But if we have a bunch of secretions that build up, it's sort of going to block. And so we can have obstructive airways with the secretions as well. And then we can also get hyperinflated alveoli, right? Where we have gas that can come in during inhalation, and then when they exhale, gas can't get back out, so that gas gets sort of stuck in there, and so that can cause hyperinflation. So not only can it be filled with a bunch of secretions like we see up here, but it also can be air trapping as well as we see down here. So they can have both atelectasis and hyperinflation at the same time. So it can happen simultaneously in that patient. So hyperinflation and atelectasis can easily happen. So this is an explanation of that check valve obstruction. So when we look at check valve, they just mean this. They mean the secretions turn into a one-way valve. So when they breathe in, remember your airways expand, the non-cartilaginous airways expand, and so you can get gas into the airways, and then when you exhale, your non-cartilaginous airways collapse. And so if your airways are narrowed down, especially with secretions, it'll trap that gas from coming out. And so that will cause air trapping. So atelectasis, consolidation, and then eventually fibrosis can easily happen and cause obstructions and the inability to exchange gas on these patients. All right, all their alterations you'll see with this, they're going to have that chronic dilation and distortion of the bronchial airways. And remember, there's three types. There's cylindrical or saccular, saccular, and varicose. And so we'll look at all three of those. They're going to have a lot of foul-smelling sputum. Bronchospasm is part of this. Hyperinflation, air trapping, we already talked about this. Atelectasis, remember, both these are happening simultaneously. Constriction or consolidation of in parenchymal fibrosis. So a lot of areas where we're turning destroyed airway walls and tissue into pretty much scar tissue. And then you might also see hemoptysis with this condition. Remember, it's destroying blood vessels as well. So that blood vessels, that arterial erosion would cause that hemoptysis that we're seeing. Subdivisions, right? These are the three subdivisions that we just talked about. Varicose is where it has that irregular pattern. I always think of it as a Loch Ness Monster, right? That sort of irregular humpback pattern that you would see. Dilated and constricted in irregular fashion. Hopefully this will make more sense as we look at the CTs and the x-rays. Cylindrical is your second one, or tubular. So fusiform and varicose are synonyms, the same thing. Cylindrical and tubular, same thing. These are where they're more like a straight tube or a colander, like not colander, a column, right? And so they're very tubular. They look like a straw that's in there. And finally, the last one is cystic. It's going to look like a bunch of little bubbles all over the place. And so those are your three different types, and we can really see this well on a high resolution CT scan. X-rays, we can see them, and I will point out some X-rays, PA X-rays that we could see them in, PA and laterals, and then we'll also look at some CT scans on these. Notice that this one's the largest. The greatest damage to the tracheobronchial tree happens with which one? Cystic, right? This is the biggest one, right? This is the greatest damage to the tracheobronchial trees when all these cysts start to form, all these bubbles, right? The bronchial walls in cystic, it destroys cartilage, elastic tissue, smooth muscle. All these things are just getting destroyed. And then when that happens, that's when these sacs start to appear. So they're evidence of tissue that has been destroyed in the respiratory zone. It's pretty crazy. Remember, an alternate word for the respiratory zone is parenchyma, right? So that's something that you'll see there, but cystic is the greatest damage to the tracheal bronchial. All right, risk factors for cystic, or not cystic fibrosis, for bronchiectasis. Cystic fibrosis is going to be a big predetermining thing for bronchiectasis. So people with cystic fibrosis are very prone to bronchiectasis, right? This is the most common cause of bronchiectasis. The most common cause of bronchiectasis. The most common cause of bronchiectasis is cystic fibrosis. Hopefully you got that down. The most common cause of non-cystic fibrosis bronchiectasis is pulmonary infection. So what type of patient population have we talked about so far that is very prone to pulmonary infections? I'll give you a hint. Hopefully you got my hint, right? That's your COPD population. Recurrent pulmonary infections can cause bronchiectasis. So in these patients with chronic obstructive pulmonary disease, they're very, very prone to getting bronchiectasis as well. Remember, because they're very prone, their ability to fight off infections, their ability to have their normal protective mechanisms work are impaired. And so they're very high intensity to get a bronchiectasis as well. So the most common cause of non-cystic fibrosis bronchiectasis, infection. The most common cause of bronchiectasis all period whatsoever, is going to be cystic fibrosis. If they don't have cystic fibrosis, the most common cause is infection, right? So cystic fibrosis is the most common cause overall of bronchiectasis, but for non-cystic fibrosis bronchiectasis, the most common cause is an infection, and that's where you're looking at other things. So individuals can also get it from things like PCD, primary ciliary dyskinesia, where the cilia aren't moving. Immunodeficiency disorders, where their immunoglobulins aren't quite working right, so their ability to fend off infections are there. Same thing with an autoimmune disorders. People that have issues with their bowels, things like that, can easily develop it as well. Not easily, but they can develop it as well. All right, so you're in your Pima scrubs, you're wearing your Pima stethoscope, you're imagining yourself right now sitting in an ER or working around in an ER doing EKGs on people, ABGs, all that good stuff, and they say, hey, we got a person that's coming in that's working hard to breathe and they're sweating and their SATs are low. Can you go in there and see what you think? Well, if a person had bronchiectasis, what would they look like to you? Well, they would be tachypnic, they would be tachycardic, they would be hypertension, right? You're going to see them working hard to breathe. They're going to be using their accessory muscles. Their AP diameter would be increased, remember, because they have that hyperinflation, and so their AP diameter would be a lot more barrel-chested. Right, digital clubbing, we talked about this before. This is not you going to the clubs and listening to electronic dance music, right? This is where you see their fingers along the tips of their fingers sort of bulbed at the end because of that hypoxic vasoconstriction. Cyanosis, of course, so you're going to give them oxygen, right? Peripheral edema, this is because if they have this hyperinflation, right? Remember, this is the rib cage and this is the lungs. You have this thing called the vena cava, superior and inferior vena cava. If the lungs are hyperinflated, they're going to squish the vena cava in the thoracic cage, which means blood's going to back up. And then if they got, let's just say this is their Frankenstein, okay? They got a giant boot. Blood's going to back up into their feet and cause a lot of edema, right? So that's what we're looking at here. So peripheral edema can be part of this as well. Cough with sputum. And here's the thing, it could show hemoptysis. Remember, we talked about that hemoptysis part with destruction of the arteries or the capillaries that are in their lungs too. Other things that you'll see at bedside evaluation, I know there's a lot here. If you were having them do fremitus, that would be decreased. Their percussion note would be drum-like, right? With the air trapping, it would have that drum hollow sound to it. Breath sounds are going to be diminished usually. You might hear wheezing and crackles, especially if they have bronchospasm, or they might have crackles because of all the secretions going on in their lungs. So that's something that you'll have to look at. Now, this is if they have the obstructive form. If they have the more restrictive form, this is sort of in the later stages where we have a lot of destruction of tissue and it goes from being obstructive to now being restrictive. This is where we have the formation of all that scar tissue. And so when this happens in the restrictive thing, what would they look like here? Well, if their fremitus would be increased because there's more dense tissue. It's more solid and dense, and it's going to reverberate, have that more transfer of sound. Breath sounds are going to be deep tone, bronchial, sort of like if you guys ever looked at a guitar and you see all the, or a violin or any of those stringed instruments, and you're going to see the strings, one string's thicker, the other one's slightly less thick, the other one's thinner, right? And so as the string is bigger, it creates a lower bass tone note. Hopefully this isn't a music lesson for you. But when we see a lot of inflammation, we see the swelling, we see a more surface tissue, and that's what creates that sort of deep bronchial breath sound that we're seeing there. Crackles, of course, more from atelectasis. Some secretions, of course. Westward pectoriloquy also could be noted because there's more dense tissue, so that's more transfer of sound. And their dull percussion note, if you did the chest tap for diagnostic percussion, not therapeutic, but diagnostic percussion, this would be more of a muted, dull, dull sound that you would hear. So it'd just be sort of that deep, pale, muted sound to it instead of this drum-like hollow sound that you would see with the obstructive. X-ray. So X-ray, these are going to be fun. Hyperinflation for sure. You can also see atelectasis, like I said, simultaneously on these patients. Diaphragms, we're going to see they're going to be flat, depressed diaphragms. You're going to see instead of the arches, you're going to have that sort of that flattened CP angle instead of your nice McDonald's arches there. Increased opacities, for sure, all the inflammation, all the secretions, all that bad stuff. So fluid-filled airways, we'll see lots of that. Crowding of the bronchi, this is because all that mass is collecting together. So if you have a bucket and it's empty, there's no water or anything in it, and then over here you have a bucket that does have water in it, which one's going to be heavier? Well, the one with all the water in it, right? So when you have airways that are filled with a bunch of fluid, they create more mass and gravitational force, and then they're going to crowd together because they're going to be sunken to the gravity. Bronchograms can confirm cylindrical, cystic, or varicose, and I'll show you examples of all three of those as well. Honeycombing pattern, usually you'll see in those sort of that later fibrotic stage. Nodules, especially in cystic. Long, tall, narrow heart. This is just like the hyperinflation we talked about with COPD, right? You got that tall, narrow heart being squished because the lungs are hyperinflating and squishing all those things in. All right, so in this one we're looking at the apices. So when we're looking at this, we see these little things that are forming up here that look like cysts. Do you guys sort of see these circular things in their apices? Right, and then when we look to their bases, and start to see them here. Oh heavens, there's lots of them. So A is for apices. Yeah, we do have some of these going on in the apices, for sure. B is bases, right? This is where we have that flattened hemidiaphragm. Remember, flattened doesn't mean like it forms the shape of an L, or it's flattened because we don't have that arch, right? Normally you should have that arch for the hemidiaphragms, and you don't. Right, now on the right side here, the right side of your screen, but on the left lung, you have down here, you see that this CP angle is also a little bit flattened, not flattened as much, but a little bit flattened there. C is cardiac. You see how the heart is sort of constricted or pushed in. It's not as wide as it normally should be. That's that tall, narrow heart thing. ABC. D is diaphragm. We have 11 ribs, 10, 11 ribs here. E is esophagus. We don't have any OG, NG tubes. F is for fissures. I don't see any fissures here. G is for gastric. I don't see any gastric issues. H is for hilar. Yes, there's a lot of hilar infiltration here. Oh heavens. Do you not see that? And there's even cyst here in that right middle lobe. You can even see bronchial cupping. Bronchial cupping here as well. That's that highlighter, that inflammation that's going on there. Then the interstitium, and that's what we're looking at here with all these bubbles. What type of bronchiectasis do you think is going on here? Where they're forming sac-like structures. You should have said cystic, right? And usually you'll see these, and this is just a PA x-ray, right? We may not even need a CT scan with this patient, but you can sort of see how much destruction of the lung tissue is going on here. Okay, so now we have this patient. This is more confined to the lower lobes. So what do you see here? So A is for apices. Do you see as much going on in the apices? And hopefully take some time, do the A through I, pause the video, right? Do an A through I, and see what you see. All right, so you went through the apices, right? And you're looking for things. Not a lot is going on. There might be some infiltration going on there. But when we're looking at this, we're looking at mostly lower lobe stuff. So B is for bases. Do you see a good arch in your base? Right, I don't see a great, fabulous arch in our bases. Still, there's some flattening there. Down here, way more of an arch. So the left lower lobe has way more of a curve to it than that right lower lobe. That right lower lobe is still more of a linear line there. And so we have some issues here. What do you notice about everything in the thoracic cage? It looks like the mediastinal area is sort of shifted and being pushed to the right of your screen, which would be towards this patient's left lung. So what we have here is that sort of what's called a mediastinal shift, and it's caused by all this left lower lobe issue going on here. This left lower lobe is full of consolidation and heavy fluid and secretions. The right side has some of it, but remember, the right side has more surface area than the left side, so it's going to be more exponential on the left side that it would actually cause that shift because there's more overall surface area to even out the pressure on the right side. So you see a mediastinal shift and left-sided translucency, sorry, transopacity when we're looking at this. So this person has volume loss on their left side. Which type of bronchiectasis do you think this patient has? Do you see hollow tubes? Sorry, do you see irregular patterns like varicose veins? Do you see hollow tubes like cylindrical? Or do you see sacs like saccular or cystic fibrosis, right? So this would be, when you're looking at this, trying to circle these. Right, this would be left lower lobe bronchiectasis. There is some on the right side as well, but you can sort of see, right, and hopefully you were able to go through this as well and sort of see that cystic bronchiectasis. All right, so we're going through this, we're looking at this. This is the spinal column here. This is your hemidiaphragm here. When we're looking at this patient, and so when we're looking at this, what do you notice? And this is a lateral x-ray. So the patient's faced towards that direction, their spine's back here, their sternum would be where this arrow is, face that direction. So that person's faced that way. So you're sort of seeing the cardiac shadow here. This is a lateral x-ray. And so when you're looking at this, what do you notice? All right, we can do our A through I, and you can pause it and go through the A through I and practice that. I would recommend it, but when you're looking at this, what are you guys seeing? Are these irregular pattern, cylinder pattern, or saccular? Right? If it's me, and I definitely see more of that column or cylindrical pattern here, that's going on here. So this would be a cylindrical bronchiectasis that's affecting sort of that whole area. And you notice here how much this whole lobe is sort of just consolidated and collected together compared to the apical part of the x-ray. That's because all that mass there. Remember we were talking about an empty bucket versus a bucket full of water? It's that mass that's sort of collecting it all together. Okay, so we got another lateral chest x-ray. So with this lateral chest x-ray, the spine is back here, the sternum's over here. This is the cardiac silhouette over here. And what do you notice on this lateral x-ray? Oh heavens. You should see this, right? You see this? It's pretty significant. Bubbles. All these bubbles. So what type of bronchiectasis do you think this is? Remember, there's three types. There is the irregular varicose type. There's the cylinder column type. And then there is the cystic type. Which one do you think you see here? All right. So this is definitely a saccular or cystic bronchiectasis. Lots of it going on here. You can see it's just filled with that goo, that anaerobic goo that's going on in there. Foul smelling, probably hemoptysis with this. You can even see the bronchial cuffing up here in the apical regions a lot more. So that's what bronchial cuffing looks like in a very, very good image overall. Okay, so what do you see here? So we got another lateral x-ray. I know you guys are loving lateral x-rays. I do, at least. And if I do, that means you do. That's right. So when you're looking at this lateral, here's the diaphragm. The sternum's up here. The spine is back here. Sorry. Maybe we'll start with an S. But the sternum's up to the right of your screen. The spine is to the left of your screen. As you can see, the spinal column there, and the ribs curve down. So what type do you see here? Remember, there's three types. There's your cylinder, there's your saccular, and then there's the irregular, I call it the Loch Ness one. All right. So what do you see here? So pause the video and sort of see what you think you see. Which one of the three types of bronchiectasis is this? Right, so hopefully you were looking at it and you were seeing how irregular these areas are down here. You see how they're all squiggly? Squiggly? Do you guys sort of see this one down here that's squiggly? That one's that's squiggly. That one that's squiggly. Hopefully you can see my squiggles. See how irregular and squiggly these little guys are overall? right? And so this would be an example of a varicose bronchiectasis, right? And this one is a patient with ciliary dyskinesia, so they can't clear their secretions, and it's mostly those basal segments that are affected with these patients, right? Don't see as much going on in the apices, most of it's in that base there. So hopefully you see some advantages to lateral x-rays now that you've seen both PA and laterals with the different types of bronchiectasis. Which view of the x-rays do you think was more valuable, the laterals or the PAs? Just saying. All right, high-resolution CT scans. We love high-resolution CT scans. They are your best friend. It's like a significant amount more radiation the patient gets for CT scan than an X-ray, but it can usually see a little bit more detail. We can see how thick and dilated the tissue is. We can also see how significant the clusters are. Signet rings can show up pretty easily, and we might see some flame shapes as well. So let's get into some examples. So over here on the left, you will notice these are the signet ring signs when you're looking at this. These little guys here, these signet ring, these circles, these sacs, that's what you're looking at on the CT scan on your left. So remember with CT scans, your spine is down here at the 6 o'clock position, your sternum's up here at the 12 o'clock position, and it's a mirrored image on a CT scan. So this is actually the left lung over here, and this is actually the right lung over here. So just keep that in mind. It's like Facebook Live where it just mirrors that image. The orientation's correct. It's just you got to know which one's the right lung and which one's the left lung. So when we're looking at this, we see those signet rings. So this is a sign of cystic bronchiectasis, and this is a person with cystic fibrosis on that left here. So you can sort of see those signet ring patterns that you would see on that CT scan. So it's a pretty clear sign of a cystic form of bronchiectasis, and this one has cystic fibrosis. So when we're looking at the patient on the right, you see, what do you notice about, and there's arrows pointing towards it. You guys see these arrows on the CT scan on the right? They're pointing towards these tall, narrow, pretty linear columns. So this would be a form of cylindrical bronchiectasis, and that's what you're looking at here. And then this is sort of a segment of the upper lobe, so you can sort of see where the aorta and all that stuff are here. And I have a separate CT lecture, but it's not for you guys, not yet. Bronchi are wider than normal, and they'll taper as you get towards the lower part. So here's a CT scan of cystic fibrosis on the left, or cylindrical, and on cylindrical on the right here, just so you could sort of see the difference of what they would look like on a CT scan as well. Okay, so on your left, pause it, see what you see. Hopefully you paused it and evaluated for yourself. That's the only way to get better, the more you use your brain to recall the information there. Hopefully you've seen some irregular patterns going on here. And so on that left, you're going to see more of that varicose, irregular pattern going on. Right? You see it almost like little bubbles in there that just irregularly go. So that's going to be varicose bronchiectasis on your left. And this person has aspergillosis and cystic fibrosis, so their CF made them more prone to infections, and in this person, they got a fungal infection. Boo! So that's what's going on here. Usually it's going to look beaded or corrugated in appearance, so it's going to look like a bunch of beads put together. And then on the right here, you're going to see cystic bronchiectasis that has really, really advanced and even to the upper lobes. So this is a pretty severe case of bronchiectasis on the CT scan on your right. And it looks like this is what's called that honeycomb pattern. When we talked about the honeycomb pattern, just all these areas here, right, that just look like a honeycomb. Pretty severe. You even see it in the peripheral airways as well. It's just bad altogether, and I could spend time circling all of them, but you guys should be able to see that. Okay, so what would their PFTs look like? We looked at radiology reports. What would their PFTs like? Well, remember there's two types here. We have both a restrictive type and an obstructive type. So when we're looking at obstructive type down here, their flow rates are going to be low, and their volumes are going to be normal. And then when it advances to the restrictive stage, it's going to be their volumes low as well. And it has those in here, and I took this directly from your book as well. So this is not something that's new, but their volumes will be low, of course. Their forced vital capacity will be low in the restrictive. MVV is going to be low in both. I'm trying to think of anything abnormal. Peak flows will be decreased on both. So you're going to see those two patterns, restrictive and obstructive. It sort of depends how severe their disease is, how long it's gone on. It's sort of a gray area, and I know how much anybody loves gray areas. Well, this is sort of something that you will use in the PFT lab, but not something you might use in the ER for these patients if they can't breathe and they have like an aspergillosis going on. So in the emergency department, what would you do, right? How would you determine the severity of what is currently going on with them? It doesn't really matter if it's restrictive or obstructive right now. Now you're going to see a difference in their bedside assessment of when they're restrictive versus obstructive. But when we're looking at this, how severe is their current clinical condition? Well, an ABG might be able to help you sort of determine how bad their condition is. So when we're looking at the severe stage, they're going to be in that compensated acidosis, that compensated state when we're looking at this, because they've usually had it going on for quite a while. And if they're just had an acute episode, they're going to be in that alkalosis that happens. And the alkalosis, remember, happens because they have that hypoxic drive that kicks in with the peripheral chemoreceptors and tells them to breathe faster and deeper. Well, when that hypoxic drive kicks in and breathes faster and deeper, that's when they go into an alkalosis, and that's what makes it that mild moderate stage. When they go back to a compensated stage, that's when they're going into respiratory fatigue, right? Oxygenation, so this is a shunt-like process. We have blood flow that's going through the lungs that's not exchanging gas, so perfusion without ventilation is the definition of shunt. Of course, you guys have that memorized. So this is a shunt-like process, which means their CaO2 is going to be low, which therefore means their DO2 is going to be low. So remember, from pulmonary AMP, CCO2, CaO2, CVO2, and then your tissues were down here somewhere. So if your CCO2 is low because you're not ventilating, you're obstructing, you're not getting rid of your CO2, you have blood flow. So your capillary content of oxygen is low. If your capillary content of oxygen is low, even if you had good diffusion, you're still going to have a low CaO2, and then you're still going to have a low CVO2. Because you start off with less, you're going to have less downstream, right? It's just sort of like a river that has a dam in it, right? So you're going to have that restriction of that flow that's going to decrease the amount of water that goes down stream overall. So that's what we're seeing here. So your DO2 is going to be low. Your consumption, your VO2 is going to be normal. I'm trying to write the letter N here. Normal. Your A to B gradient's normal. Remember, there's nothing hypermetabolic with the tissues here. O2-ER is going to be increased. Remember, the O2-ER is increased because it's going to be increased because we're not extracting more than we normally are. We're taking the same amount. Our tissues are taking the same amount of oxygen from the bloodstream as they normally would be, but we're starting off with a lower amount to begin with. So out of the amount that we started with, we took out a higher ratio of what we started with than we would originally. And that's why our O2-ER would technically be increased, because our DO2 is decreased. Venous saturation would be decreased, where we talked about that here on the right, how everything downstream would be low because we start off with the low capillary content. Hemodynamics. Okay, so here we have the lungs, we have the left side of the heart, the right side of the heart, and then we'll do like the vena cava. So let's just do the vena cava as a CVP. All right. Then we'll do this as pulmonary artery pressure, and then we'll do the lungs as pulmonary vascular resistance, and then we'll do this part as the pulmonary capillary wedge pressure. Cardiac output doesn't change, so cardiac output is normal. So remember, our issue here, we have hypoxic vasoconstriction. We're not ventilating very, very well with this at all. And so we have pulmonary capillaries are constricted. So that means our pulmonary vascular resistance is going to increase, which means our pulmonary artery pressure is going to increase. Remember, we're just backing up a bunch of pressure, which also means eventually our CVP will also increase as well. We're backing up that pressure. The accident is here. Now, is there anything going on with the left side of the heart? Right, the left side of the heart, as long as they don't have an underlying condition, this left side of the heart, that left ventricle, as long as nothing's bad going on with it, should be functioning to pump out blood to the aorta just fine. And so pulmonary capillary wedge pressure should be normal. So understand, with almost all of these pulmonary conditions, the left side of the heart, unless they have an underlying condition, shouldn't have an issue. All your right-sided heart pressures, which are all these guys here, are usually going to be an issue. Hopefully that made sense. Lab tests with bronchiectasis, they're going to have increased H&H. They're more prone to polycythemia, especially over long term. So that's something that we'll look at. Elevated white blood cells, that's usually a sign of active infection, of course. So you'll see that on a CBC. Sputum, if you do a sputum culture, usually these are your anaerobic organisms that you're going to see. So Pseudomonas, very common, H. flu, strep, those are some things that you might detect in a sputum culture. So what do? This patient comes in, they're working hard to breathe. We get an x-ray, we give them some oxygen because they're hypoxic, right? We talked about their hemodynamics and how much hypoxic vasoconstriction can affect all the right side of the heart pressures. Well, here we go, oxygen, that'll help with the pulmonary vasoconstriction. Also, things that will help them ventilate better and get more oxygen. Airway clearance therapy, say hello to that, especially with bronchiectasis. So this could be directed cough, exercise breathing programs, autogenic breathing, I love that one, forced expiration, the huff cough, CPT, chest physiotherapy is going to be one of the big things. With these patients, anything that can get the secretions moving, suctioning them if they're on ventilation. Positive pressure, remember that helps distend the airways. So there's gas that's able to go past these little mucus plugs and back pressure them to sort of help push them up and out. Oscillatory PEPs, those are all things that can help both shake secretions loose and mobilize them as well. The oscillations, anything that helps mobilize those secretions. Lung expansion therapy, so those are things that do positive pressure, especially with those areas of atelectasis, help them reopen up. Drugs, expectorants, antibiotics, nebulizers, for bronchodilators and other things as needed, of course. If their CO2 is super high or if they're going into an acidosis, assisted ventilation might be needed on these patients. So diagnosis. So how do you diagnose this one? Well, one of the best ways to do this is a high resolution CT scan. It's made on the basis of the diameter of the bronchi and the pulmonary artery. So we're looking at sort of a change in between there, and that's how they sort of help diagnose this. So that's one of the key diagnostic factors for bronchiectasis, is getting a high resolution CT scan. You can do PFTs, but it's looking at more if it's obstructive versus a restrictive issue going on. It doesn't really tell you what type of bronchiectasis it is, or tell you the severity of the bronchiectasis. It'll tell you the severity of the lung function, but it won't tell you the severity of the bronchiectasis like a CT scan would be able to. ABGs in the hospital can help you confirm what stage they're in. Are they in a mild stage, moderate stage, or severe where they're in an acidosis, right? Alkalosis, or alkalosis, normal pH, or an acidosis, right? That's going to be sort of telling you what stage they're in an emergency situation. All right, quick review questions. I'm not going to answer these. These are for you to answer. What are common lung alterations that occur with bronchiectasis? There are at least 4 things I can think of. Ooh, heavens, I hope you remember. What might you find at the bedside evaluation? What would their patient assessment look like? What would their heart rate? What would their respiratory rate? What would their sputum be? Would their sputum smell? Would it not smell? Would it have blood in it? Would it not have blood in it? Would it be white, or would it be thick, copious mucoid? Would it be thick, copious, and foul smelling? Tell me what's going to be going on with this patient. Would they be increased AP diameter or decreased AP diameter? What's going on? What would be their patient picture of a patient with bronchiectasis that was in the ER in front of you? If you did an x-ray, what might their x-ray show? So even think about what their x-ray would show if it was cylindrical. What would their x-ray show if it was varicose? What would their x-ray show if it was saccular or cystic, right? So what would their x-ray show? What would the heart look like on their x-ray, right? So these are all things that you need to be sort of looking at. What would their costophrenic angle look like? What would their diaphragms be? Would they be elevated or flattened, right? Do you have arches? Do you have flat angles? What would their ABG look like? Coming in, if it was a mild stage, moderate stage, acute stage, what would their ABG look like? What about their hemodynamics? What type of process? What would happen with their right-sided pressures? What would happen with their left-sided pressure? What would be their oxygenation status? If you did a pulmonary function test, what would it look like if they were in the restrictive category? What would it look like if they were in the obstructive category? What would it look like if they had a combined condition, like in the severe late stages? Anything abnormal about this sputum? Is it growing anything? What color is it? Does it smell? Does it not smell? What type of anaerobes could it be showing? Ooh. What would the lab test show? What would you see on their labs? Anything abnormal? Especially a CBC that looks at platelets, red blood cells, white blood cells, things like that. What would their lab test show? And then, what would you do with this patient, right? Oxygen? No oxygen. Airway clearance, bronchodilators, anti-infectives. What would you do with them? Please take some time to ponder these things. Okay, so cystic fibrosis, let's start talking about cystic fibrosis, and you'll sort of start seeing why I included it with the bronchiectasis presentation. Although the lungs of patients with cystic fibrosis appear to be normal at birth, abnormal structure changes can develop quickly. So these kids, people with cystic fibrosis, are born with this condition. They have bronchial gland hypertrophy and metaplasia of their goblet cells. So they're going to have some big issues going on. They're going to ultimately, that leads to excessive production and accumulation of thick tenacious mucus in the tracheobronchial tree. and they'll have inadequate hydration to the sole layer. Remember the sole and the gel layer? The sole layer is the one underneath that's thin and watery, where most of the cilia will move through. The jelly is the thick, viscous one that's on top. So that sole layer is going to be dried out. So the cilia aren't going to be able to move and have that normal wave-like factor to clear their lungs as much. So they're going to have a lot of retention of secretions as well. So their mucus is going to be thick and flexible. They're not going to be able to clear their secretions very, very well, and they'll have a lot of mucus plugging as a result. They're going to have overdistension and plugging of the alveoli. They're going to have atelectasis. In some cases, they're going to develop bronchiectasis, right? And so that's what we're looking at here, is that destruction will eventually start causing bronchiectasis on them. It can result in both restrictive and obstructive characteristics. Bronchial obstruction, hyperinflation are going to be some of the big things that you'll see with CF in advanced stages. It's pretty bad. Alterations that are associated with cystic fibrosis, and you'll cover cystic fibrosis a lot more in pediatrics class as well. A lot of accumulation of thick tenacious mucus in the tracheobronchial tree. Hydration is going to be an issue here. Bronchial obstruction, hyperinflation of the alveoli. That's that whole check valve thing too, where they have so much secretions that during inhalation, gas can get into their lungs, and then during exhalation, when their airways are smaller, right, it creates a blockage so that gas is now trapped on exhalation. So total bronchial obstruction with mucus plugging, of course, all that mucus can just slide down into the respiratory zone and just clog up a bunch of airways and cause atelectasis at the same time as causing hyperinflation, like what we've seen with bronchiectasis, of course, bronchiectasis. And then, of course, these patients can still have bronchospasm on top of all of this. Oh, heavens. Oh, heavens is right. All right, so with cystic fibrosis infection, if they do get an infection, it stimulates more mucus to be produced and will further compromise their already diminished ability to transport mucus. So for these people to get infections, it's pretty serious, and they have to be very proactive, and they'll even cycle through different infective agents to help them as well. As this CF progresses, the patient might get signs and symptoms of recurrent pneumonias. Chronic bronchitis might develop as well, bronchiectasis, of course, and then they might develop lung abscesses as well. So this is sort of what you're seeing from the book, atelectasis, mucus plugging. You might see a lot of issues where you have hyperinflated alveoli. That's secondary cause to all this, and this is everything we've covered so far, so I won't spend too much time on this slide. The most common fatal inherited disorder of childhood, according to your book, is cystic fibrosis. It is an autosomal recessive gene disorder, and it's usually located on chromosome 7. This is CFTR is the big thing to remember with this. The cystic fibrosis transmembrane conductance relator. Like I said, you'll go over more of this in pediatrics, especially when we're talking about pediatric patients. My experience with cystic fibrosis is on the adult patients that would come to Swedish every once in a while, but so that's why pediatric class is going to be more beneficial when you're talking about this. It's the expression of the CFTR that is looking at their sodium chloride ions, and that's going to ultimately affect the lining of their airways, their intestine motility, their pancreas and liver ducts, even their sweat glands are going to have a high sweat chloride level. And so that's one of the ways that we can actually diagnose it is what's known as a sweat test, which we'll talk about at the end here. You're going to see with this condition viscous mucus that just accumulates the lungs, mucus plugging. They're going to have enzymes that are prevented from reaching their intestines. So you'll see some GI disorders. They're not going to be able to digest protein and fat as much. They have to usually be on dietary supplements. And then they're going to have an issue with needing things like fat-soluble vitamins like A, D, E, and K. Especially with these patients. So nutrition is going to be a huge factor in their ability to recover as well as maintain good function normally. So they'd be more prone to things like diarrhea, malnutrition, failure to thrive. A lot of these kids will be ultimately just sort of that failure to thrive in the adult patients. They know themselves very well and they just get tired of fighting it. It's very sad. How is it inherited? It is a recessive gene disorder. You have to have 2 copies of it. One from each parent. So if one parent is tested and they do not have the carrier for it, then the kid will not have cystic fibrosis, right? So both parents have to have a carrier for it, and so this is something they can test, do a blood test for on parents before they have kids to sort of see their chances of it. There is a 25% chance that each child will have CF. If both parents are a carrier, a 25% that each child will be completely normal. In other words, they won't have it at all. And a 50% chance that each child will become just a carrier. Doesn't mean they'll have it if they're a carrier. And then finally, when both parents carry a CF gene mutation, there is a 1 in 4 chance that the child will have CF. Well, that's just saying that's that 25% chance that we were talking about here. Ultimately. And this is the picture that your book supplies when we're looking at this. And this is just trying to give you a visual representation. So if these things throw you off, that's okay. This is just, instead of using words that we used in the previous slide, this is just using a picture. So it's both parents in the upper left corner here. We're carriers, and there's a 1 in 4 chance that that kid will be unaffected by it. In other words, no issues whatsoever. There's a 1 in 4 chance that they will have cystic fibrosis, and then there's a 50% chance that they'll be an unaffected carrier of the disorder. If one parent, so this is all that you're looking at here. So if one parent has a non-carrier whatsoever, so let's say they test mom, so let's say mom's pregnant and she wants to know if she's a carrier, just to see if there's a possibility their kid could have CF. So if mom gets her blood tested, or whoever gets their blood tested, and they're a non-carrier, then there is a 100% chance that they'll be an unaffected situation. So this is just sort of that visual representation of what we were talking about on the previous slide. All right, so what will CF patients look like at bedside when they have sort of an exacerbation type thing going on? They'll be tachypnic. Anxiety goes along with almost every respiratory disorder going on. Ooh, this is the first time we've seen this. What is this one? Pyrexia is my fun way of saying fever, right? Usually that's because of the infection. Tachycardia, we've already talked about that. Hypertension, accessory muscle, increased AP diameter, cyanosis, digital clubbing. A lot of this looks very similar to bronchiectasis. Edema, sputum with hemoptysis. A lot of this looks like bronchiectasis. Increased firmness, hyperresonant percussion, just like bronchiectasis. Diminished breath sounds, crackles, wheezes. This all looks a lot like bronchiectasis. On their x-ray, translucent, dark. Lung fields can be noted in the hyperinflation part of this disorder. Flattened diaphragms, once again, that's the hyperinflation part that goes with it. Right ventricular enlargement, cor pulmonale. We talked about that with the picture we drew where we have that back pressure of all the right-sided heart pressures, and that affects the right side of the heart can distend and then cause your CVP to extend as well. So it's sort of that back flow and that back pressure that can ultimately cause cor pulmonale in these patients. Atelectasis and fibrosis can also be seen. You might be able to see their cystic formation. Remember, there's 3 forms of bronchiectasis. On these patients, you'd see cystic. on their patients. You could see pneumos, spontaneous pneumothorax as well from those areas. Abscesses occasionally. Late stages, you might see residual volume and functional residual capacities change as well on these patient x-rays. Okay, so what do you see here? Hopefully you took a little time to pause and think through this. Look at the apices, look at the bases. Do you notice any type of issues going on? Well, in the apices, do you see much going on? I hope you guys are interacting, please. So yeah, there's a little bit of hazy infiltrates, and we do see some of these guys going on here. Bases. Do you see a good arch, or do you see sort of a flattened look to it? Do you see perfect arches, or do you see flattened? So this patient's hyperinflated. C is cardiac. A little bit of a narrowed heart there. D, diaphragm, we're definitely hyperinflated here. We're at around 10 to 11 ribs. A, B, C, D. E is esophagus, no G tubes. F is for fissures. I don't see the fissure. Unless this is it. I don't see the fissure. G is gastric. I don't see a gastric issue. H. Hilar infiltration. Absolutely. A lot of hilar haziness, opacity. That would be a sign of bronchial cuffing there as well. And then you can sort of see this bronchograms too. A, B, C, F, G, H, I, interstitium, and that's where you're looking at all these guys here. Do you guys see all these cysts? They're not easy to see, and I love this picture, this x-ray, because they're not as easy to see. But hopefully you can see them a little bit easier now that I've circled a few for you, and they're all over the place. So hopefully you see this, and so you would say that this is sort of a bronchiectasis with cystic formation. So that's a sign of a hyperinflation cystic bronchiectasis. All right, what do you see here? So pause it, see what you see. Hopefully you go through your A through I or whatever it is. So on this patient, you're looking at what are some of the things. The apices, do you see a lot of stuff going on in the apices, especially in that right upper lobe? There's some stuff going on. There's some stuff in this right lower lobe especially. A, B, B is for bases. Do you have good arches, or are these more of a flat angle? These are more of a flat angle, so they're hyperinflated. C is cardiac. What do you notice about the heart? Tall, thin, column-like heart. So A, B, C, D is diaphragm. We're once again at around 10, 11 ribs. 11 ribs or so. A, B, C, D. E is esophagus, nothing in there. F is for fissures, don't see the fissures. G is gastric restriction, don't see that. H is hilar infiltration. Oh heavens, yes. You want to skip steps and move right to infiltration, but sometimes it just doesn't work out. But you see this especially in that lower lobe going on, so especially in that right lower lobe. There's some going on in the left lower lobe atelectasis as well, but especially in that right lower lobe, we got a lot of stuff going on down there. And if you zoom in, you can see some of these cysts going on. So this would be saccular or cystic issues going on. Okay, so this one I took directly from your book, and this is looking at a 26-year period of a patient, and they're just looking at the progressive changes in the cystic fibrosis. So letter A over there on the top left is at 3 years old, and the patient has like a right middle lobe pneumonia that's going on. So you can sort of see how dense and consolidated that right middle lobe is on this patient over there. And then remember, right lower lobe is posterior, so that's one of the things that you'll notice there. And the way that you know is if there's a defined line in between the heart and the area, then you know it's right lower lobe. If there's not a defined line, then you know it's right middle lobe. So this is right middle lobe, but that's for maybe a more advanced lecture later on. So at 3 years of age in A. B, they have bronchial thickening, and that's what these arrows are pointing towards, so I don't need to draw on that one, thank goodness. Bronchial wall thickening, so that would be a sign of bronchial cuffing and inflammation that's going on. And this is a kid that is at 7 years old. And then at C, down in the bottom left, this kid is 15, and this is their x-ray, right? And this is that progressive hyperinflation that you're looking at on this kid, and the hilar areas are starting to get a lot more infiltrated, a lot more significant than what we were seeing previously. And so that means there's more destruction and dilation of those bronchioles. You can see the hilar, and then on D on the bottom right hand, this kid's now 29, and these are very, very common cystic fibrosis findings, and this is a lateral x-ray that we're seeing down there. That's why it looks a little bit different, but this is showing to that barrel chest formation that you see sort of with that recurrent chronic air trapping that's going on. So in this one, you're seeing tubular opacities that are also starting to show up on this patient as well. Pretty interesting. So those tubular opacities are consistent with mucus plugging as well. So even someone with cystic fibrosis, bronchiectasis, can still have a tubular formation, and that's something that tubular formation just means that there's usually mucus plugging that's present. Okay, so on cystic fibrosis, what would their PFT shows? Well, all these things that we're looking at here are going to be, well, when we're looking at this, we're going to look at their volumes and their flow rates before we get to DLCO. Volumes and flow rates are all going to be decreased, as well as their MVV. So forced vital capacity, FEV 1%, peak flow rate, 25 to 75, 200 to 1200. MVV is going to be decreased. Now let me ask you this. What would their DLCO be? So most of the times their DLCO will be either normal, and then in the fibrosis, the end late stages, it can be decreased. But just in general, think of it as normal. In this condition, I want you to think of the only obstructive condition in general that causes a low DLCO is emphysema, right? So in this case, most of their DLCOs are actually going to be normal. It's not an issue as much with the AC membrane as all the tissue that leads up to the respiratory zone. It's pretty bad. All right, what about their volumes and capacities? So their volumes and capacities, we'll just start at the top for once here. Their inspiratory reserve volume is going to be decreased. That's because they have a higher air trapping, or their FRC is increased. So we're squishing something, right? We can't have more in there than what we normally would. There's more gas that's trapped, and so we're encroaching on the top part of our breathing. So their IRV will be smaller. Their tidal volume is going to increase. It's supposed to be an up arrow. ERV is going to decrease. RV would increase. Inspiratory capacity would decrease. Vital capacity would decrease. FRC would increase. And TLC would increase, unless we're looking at the late stages where it causes fibrosis, and that's where it can also be decreased. All right, so ABGs in the mild to moderate stages of cystic fibrosis, we might see that respiratory alkalosis just like we see with everything else. In the more acute stages, so those patients working hard to breathe, they show up into the ER. We want to quantify how bad their condition currently is, and that's where arterial blood gas comes into play. So you're going to draw blood gas. If the blood gas shows a respiratory alkalosis, I should say compensated respiratory acidosis. So that's a mistype there. A compensated respiratory acidosis, would be a sign that this person is in respiratory fatigue. If you see an acute on chronic respiratory acidosis, then that's a sign that they're in respiratory failure altogether. So in the emergency room, patients working hard to breathe, they have cystic fibrosis. The ABG is going to help you quantify what stage of the disease or how significant the process currently is for them. Oxygenation, of course, just like we talked about before, this is a shunt-like pathophysiology. We have blood that's moving through the lungs that's not exchanging gas. That's the definition of a shunt-like effect. DO2 is going to be decreased because our CCO2 is low, therefore our CaO2 is going to be low. Our VO2 is our consumption, and that's going to be normal. Our A to V is going to be our pretty much different way of looking at consumption. That's going to be normal. O2ER is going to be decreased because our DO2 is low to begin with. That's why that's going to look like it's increased. But remember, metabolics-wise, unless they have an infection going on, it's going to be normal. Now, let's say they do have an infection. Let's say they do have an increased temperature, right? Let's say they're running 103. I'm just sort of throwing out numbers there. They have a significant fever. Now, what's going to happen with their consumption? What's going to happen with their A to V? What's going to happen with their O2ER? They're going to increase. I hope that all makes sense to you, right? It just sort of depends the level of what's going on with them. Venous saturation is going to be low as well. So hopefully that makes sense with you. You're like, what would he ask me? In general, you're going to want to know that metabolics-wise, there's going to be no change. It's going to be decreased DO2, more of a shunt-like pathophysiology. But if I say that they're running a super high fever, things like that, what would happen to their oxygen consumption and their oxygen requirements? They would be increased, and you'd want to increase their FiO2 or oxygen, things like that. All right, what about their hemodynamics? So just like the other one, just like that fancy picture that I drew before, repetition is the key to learning. All your right-sided heart pressures, all these are going to be increased once again. Drawing of the lungs. Do the left side of the heart. The right side of the heart, and then your CVP. So your issue is hypoxic vasoconstriction in the lungs and the pulmonary capillaries, which increases your PVR, which increases your pulmonary artery pressure, which will increase your central venous pressure. So all your right-sided heart pressures will increase. Your wedge pressure on your left side, as long as they don't have baseline or underlying heart failure, will be normal. Same thing with their cardiac output will be normal. So left side of the heart, in theory, should be working just fine. Right side of the heart, you're going to have that back pressure. Lab tests in cystic fibrosis. Elevated H&H with chronic hypoxemia that will help compensate for it. Elevated white blood cells, of course, with infection. Hypochloremia, chronic ventilatory failure. We already talked about that with COPD, chronic bronchitis, emphysema. Stagnant mucus as far as their tracheobronchial tree. Staph, H. flu, Pseudomonas. Does this sound familiar to not chronic bronchitis, to bronchiectasis? Some anaerobes that are going on. Gram-negative bacteria can also culture in here. So that's something just to sort of pay attention to, like Cepacia, things like that can easily be associated with these patients. All right, therapeutically, what are our goals with these patients, the cystic fibrosis patients? The big thing is to prevent infections if we can avoid infections. So that whole 6-foot thing between you and someone else that's going on with the COVID thing, that's still that's all the time. That's their entire life for these patients. Wearing masks in public, that's their entire life for these patients. So that's something that they have to do here and there as well. Reduce the amount of thick secretions as much as we can, so airway clearance therapy. Improve the airflow as much as possible. And nutrition is going to be a big key thing. Remember, we talked about their GI, their ability to get nutrition into their body is decreased, and so that's a big thing that they have to worry about. So oxygen, of course, that helps with that hypoxic thing and improves the right side of heart pressures, all that stuff. Airway clearance therapy is vital with these, and here you see a picture of a kid with one of the best oscillation clearance devices out there. Volume expansion therapy, make sure we get rid of that atelectasis so they don't retain as much. Inhaled medicines, especially. So this is where you'll be doing almost every type of respiratory medicines. You'll have infective agents, steroids, bronchodilators, mucolytics. You'll be nebulizing them all. The very last one that you're supposed to give is the inhaled anti-infective agent. So if you're asked what the order of operations to give these patients are, and they might ask you that on the board exam, would be to give your airway clearance therapy. So you would give your bronchodilators first. You would give your long-term medicines second. You would do your bronchodilator first, long-term med second, airway clearance medicines third, your corticosteroids fourth, and your inhaled anti-infection would always go last when the airways are at their most patent. So you sort of have that order of operation. Non-invasive ventilation or mechanical ventilation as needed with these patients. If we can avoid repeated positive pressure, that's always a good thing. And finally, these people can have a transplant too, and they most of the time may require a lung transplant, and that's a very good beneficial thing for them. So therapeutic interventions, we already talked about this, the nebulizers. Bronchodilator, this is what we were talking about before. Bronchodilators, antibiotics, inflammatory relators, inhaled corticosteroids, systemic corticosteroids, mucolytic agents, pulmozyme, right? That Dornase alpha is going to be your big one here because it's the DNA that's connecting to itself, more of that pus formation. And so what's going to help decrease the viscosity of their secretions is going to be something that breaks down the DNA connection. When you have normal secretions, there's things called mucins, and mucins create sulfide bonds, and that's why if you put mucomist on top of a giant mucus plug that's made of sulfide bonds, then that will hypersaturate the bonds and therefore make that secretion thin out. But let's say your mucus is mostly that DNA pus formation where there's hardly any mucins in it. Well, then you could use mucomist on it, but it won't do anything. You can use acetylcysteine on anything, but it won't do anything because that's created to hypersaturate disulfide bonds, right? So chemistry-wise, it won't work. That's why we're going to use something that dissolves that DNA, which is pulmozyme or DNase. Hypertonic saline can be used. I believe they use like a 7% hypertonic for adults or kids with it. You go over that in pediatrics as well. So acetylcysteine can work in some patients. Sometimes they use it GI, but for this case, they would use it intermittently. But on this picture here, A and B, I think I took this one from your book. This is reducing the DNA of the sputum, and so you're looking at the DNA in A, the picture on your left, which I don't think you can see A, and then after the treatment, B is the Dornase alpha, and you can see how the polymers, these long strings, are broken up by the DNA's nebulization, by the DNA's treatment. And so you can see how it sort of decreases that viscosity of that sputum. So Not just a pretty picture on the right there. That's an actual representation of what happens when we give DNAs to these patients, what happens to their mucus. All right, so diagnosing the cystic fibrosis patient, they have to show clinical symptoms consistent with CF of at least one organ system. Could be their GI, could be their pulmonary system, right? They have to have clinical evidence of the CFTR as well. And then one of the ways they can look at these patients too is look at what's called the sweat chloride test, where it has to be above 60 milliequivalents per liter on 2 occasions. Or they can also do genetic testing for these patients too. They even do a nasal potential difference, and this is something that's covered in your book. The big one that I want you to look for me is the sweat chloride testing, and that's one of the most common ones that are out there. So the gold standard for diagnosing the CF is going to be the sweat chloride test. All right, that's why I want you to be aware of that. There are other ways to do it, but that's currently the gold standard. And we're looking at how much sodium chloride there is in the sweat. So a small amount of stuff is put on the patient's skin, and it's usually to look at how much sweat chloride there is in their sweat. And so the glands will secrete up to 4 times the normal amount of sweat chloride if they do have it. And so if it's greater than 60 milliequivalents, it's considered to be a diagnostic sign of CF. So remember, they have to do this twice. And so that's what we're looking for there. And then the next picture is sort of a little baby that are doing it too. It's adorable. So that's what they're looking at here. They're just looking at how much sweat is produced on this baby, how much the constituents of the sweat, I should say. So molecular testing, we're looking at the DNA mutations. They can look at stool and as well. They can look at the parents, and then they can look at the nasal potential difference as well. These are something that you can look at. I am not going to stress too hard on. I do want you to know about the sweat test, and that would be my big things there. Feel free to go through these. They're pretty interesting stuff. So I'm not downplaying them by any means at all. All right, review questions. What are the common lung alterations that occur with cystic fibrosis? You should remember this, hopefully. What might you find at the bedside? What would they look like? If they came into the emergency room, what would be their clinical presentation, right? What would happen with their sputum? Would there be hemoptysis? Would there not be? Would it be thick, sticky? Would it not be there? What would their breath sounds be? What would their heart rate be? What would their blood pressure be? What would, so on and so forth, right? What might their x-ray show? What might their ABG show? What would it look like if what would their ABG look like if they're having a mild issue? What would it look like if they're having a severe issue? Hemodynamics, what would happen with their right heart pressures? What would happen to their left heart pressures? Is it a shunt or a dead space issue? PFT, restrictive, obstructive, both? Right? Anything abnormal about their sputum? What could it culture if it does have abnormalities? Lab tests. Is there anything abnormal about their lab tests? What would happen with their white blood cells? What would happen with their red blood cells? What would happen with their hemoglobin and hematocrit? Right? So what are some therapeutic interventions? How do we diagnose this? What's the level of sweat chloride we need with the sweat chloride test? Right? So these are all things that you should sort of be going through and making sure that you could sort of recall, just to sort of set these things apart. Please be doing those charts. They help you study and get this sort of straight. This is so much information. And I am sorry, but not sorry.